because if you don't interact, so it's of a best interest for the discussion that you all contribute as well. Whenever possible, if you answer the questions and if you come out with the doubts and queries, then it will be more useful. Sometimes you feel like nobody listening, so that's why sometimes people ask, "Can you hear me?" or "Are you there?" because because not like a lecture hall session where we can see you, but here we can't see you. So it's better if you interact with the lecturer or the person who take the class, right? Are we to wait some more time, or will there be some more coming in? Is the monitor around?
Yes, sir.
Have your group joined?
Yes, sir. Our group members all joined, sir.
Join, right? Okay. So only thing if but this is a flowing one, if people join in the middle, they will not be able to follow it properly. Because mind. We'll give a couple of minutes, right? So the pediatric group, you will have use as much as possible Zoom sessions to cover up what you're losing, right? Because I think this whole week you won't be allowed to come, and depending on the PCR results of the other staff members, will decide whether we can open up or not. So we'll have to use Zoom sessions as maximum as possible. Issue is that we can't do the newborn resuscitation class and the X-ray class. It will be difficult to do with the Zoom. We'll try. Probably, most hopefully, it will not last that long, right? So, you got 100. Still, people are joining. Now, 5 minutes past. No? So then we'll start, right? Oh, still people are coming in. No? You can hear all right, is it?
Yes, sir. We can hear, sir.
Join in this issue. We'll start now because otherwise it will be too late to finish, right? So if we just do a general discussion initially, I think there are some few third year and fourth year students as well. So for the benefit of we start with basics. So what is the purpose of taking history? Irrespective of the specialty, maybe pediatric, it may medicine, surgery, or general, whatever the subject. What is the purpose of taking history? Can somebody tell? But why do we take histories?
To narrow down a differential diagnosis.
First of all, to achieve a differential diagnosis, and then to narrow it down and come to a reasonable differential diagnosis, but you may not able to diagnose the condition at the end of history, right? So even at the end of the history, you might still have a couple of differential diagnoses, which might be further narrowed down with the examination, and the final diagnosis will be made by investigations, right? So remember, history, you might not come to a final diagnosis, right? So if you can come to a reasonable differential diagnosis, it's adequate. Anything else? Why else? So we take histories to arrive at a diagnosis, right? That's one purpose of history taking is to arrive at a diagnosis. What's the other purpose of taking history?
To have a problem list and form a management plan.
Okay, good. So have problem list and have a management plan. Okay. Anything else? Why else we take histories? Okay. That is about, that's not in a short duration. It takes a while. No, it's not purely with history. Then we want to know the etiology, we want to know the complications, right? So all these will needed for the management of the patient, right? So ultimately, you take histories to get information for the purpose of management of the patient, right? So whatever the thing that you take in the history, ultimately should have relevance to the management or arriving at a diagnosis, right? So you can ask anything, you can ask anything when you take the history, you can ask any question, but when you're presenting the history, there should be that particular information you are presenting should have relevance either to diagnosis or for the management. Right? So when you present the history, somebody asks, why did you ask that question for that patient? You should have a reason. This is why I asked that question. So you had a relevance to the diagnosis or management, right? So especially for third year and fourth year, I have students here. You might have difficulty initially doing that because you need the pathology, pharmacology knowledge to get a proper DD. So as you are starting the clinicals, you may take everything. You may take all the information and then try to figure out something, right? But as you go on with higher up with the clinicals, you should be able to give me more focus and take a history that is relevant only for that particular condition, right? So that's why you should be going on doing this repeatedly. So as you go on, take more histories, you'll be more able to get a more targeted history, right? So remember in the exam, you have only 45 minutes to take the history, examination, and problem list, and organize your thoughts and write down the history if you want to write it down, right? So it's a matter of a game with the time, right? So you have to learn to take the history at the given time. So best option is to do it repeatedly and learn how to take it within given time. And you should learn that you can't ask all the questions in that time. So unless you have questions, you will run out of time in the exam, right? So it's important to go on taking more and more histories, right? And other thing is that when you're presenting the history, you got 10 minutes to present the history, plus the examination findings, the problem list, and differential diagnosis. Right? So you should learn how to summarize your history rather than giving a lot of information, unnecessary information, so that you will waste the time. So unless you finish your history by 10 minutes, you will go on with the history and eat up the time for the discussion. And then you will not have enough time for discussion. Right? It's a matter of practice. So, so keep it in mind. So as you go on improving our history, so you should be able to focus it more, narrow it down, so that you're asking only the relevant questions for that particular condition, right? Another important thing to remember is that each and every patient is different from another patient. You can't have format and fill the format, right? So you should have with a broader mind and take history as it is, right? Because patients won't come as typhoid, patients come as TB, right? So they might present it differently. So you should be able to handle each patient in a different way, right? So we'll just see when it comes to pediatrics, pediatrics is different from other specialties when it comes to history taking. Can you tell why it's different in pediatrics? What's the difference in pediatrics compared to other specialties?
Because the patient cannot give the history.
Yeah, we are taking the history from most of the time. 99.9 times, history is taken from the mother or a bystander of a relative. A child is too small to give a proper history. Unless child is about 13, 14 years old, older child might give a history. But most of the time, we rely on third person. So, issue is that we are not getting the direct information from the patient. We get the information from the mother, right? Mother or the bystander. So we don't know what actually wrong with the patient, what patient feels, right? So always the third party we take histories, and usually it's the mother who's anxious and generally tend to exaggerate the symptom, right? So the mothers come and tell, "Mata baba sumana ke mukh kate diyala nahi, mukh pakala nahi." Right? Then you say your child can't survive for 1 week without having any food. No? When you go on digging into history, that's what actually happened is child has not taken in rice, but eaten buns and chocolates and everything other thing, and cakes and stuff, but not in rice. So what mother actually meant by saying that child has not taken anything for 1 month, 1 week is that child has not eaten rice, right? So if you just come and tell what the mother says, you might look a fool in the front of the examiner, right? So don't just come and tell what mother said. It's what your interpretation. You have to dig down to the history and get the proper information, right? And sometimes they come and say, so you just go and come and say child has headache, then you look a fool because what they mean by Isara is head is warm, child having fever. So what they interpret as Isara is the fever, right? Right? So we just can't translate it to English. So history taking is not taking history, what is said by the mother in English, not an English translation of mother's story, right? The intelligent interpretation of mother's story. That's your remember. Right? Other difference is what? In pediatrics, is third party. Second difference is compared to other specialties, what's the difference in pediatrics? Anybody?
Antenatal history has to be taken.
Yeah, there are other components that we don't take in a normal history, right? Not only antenatal history, the birth history, immunization history, the developmental history, right? So that is in detail. Now, if you get a 70-year-old man in a medical ward, you are not going to ask about his birth history. You are not going to ask about his BCG and pentavalent vaccine, no oral polio vaccine. Whether he was walking at 1 year, whether he was talking at 2 words in 1.5 years. So we don't ask about development, from a like that, right? But in pediatrics, in addition to normal format of history taking in other specialties, there are additional components in pediatric history. So the pediatric is usually longer than normal, right? So those are two differences mainly in pediatric history compared to other histories. Right? So you look at the component of pediatric history, right? Oh, so roughly these are the components of a pediatric history, right? So why we have compartmentalized them like this? Why we have given the why we compartmentalize? What's the reason? The reason is that we want you to not to miss any compartment, main component of the history. You don't want to miss particular areas of the history. Otherwise, you might miss the birth history. You must totally miss the entire part of history. So to make sure that you take in the present in the history, that's not necessarily to tell the each and every heading. You can go on telling it as a complete story. And again, you don't have to go in the same order, right? So so depending on the type of history you are going to present, the condition you are presenting, you can change the order. In addition, like sometimes you can start the history with birth history, right? So something like a problem that was started from the birth, you can start with birth history, right? So this order is given, this format is given to make sure that you take all the parts of the history without missing anything, right? In a present day, you need not to go in the same order, right? Again, you can incorporate some of the part of them into the history of presenting complaint. We will take examples and show you as we go on, right? So first of all, what here tell is the description of the patient. That is name, age, gender, and location of the patient, right? So I told you earlier, if you take any a component of the history, any information in the history, that should have relevance to the either diagnosis or the management. So what the relevance of knowing the name of the patient? Why do you want to name the patient? What's the reason? Anybody tell? Why do you want to know the name of the patient? Anybody? Yeah, for the identity. Yeah. So we are write diagnosis card, we are write prescriptions, we are write investigations, right? So for that, for documentation purposes, we need the name of the patient, right? And again, anybody likes to be called by their name, right? So to know their name, so for the management, we need the name of the patient, right? So that's the reason why we ask the name, right? So why do you have the age of the patient? What's the relevance of knowing the age of the patient? Sorry? And a good example. An example? Say a 5-year-old child coming with acute onset shortness of breath, right? Will you consider bronchiolitis there?
No, sir.
Right. Whereas a 6-month-old baby coming with breathing difficulty, what will be more up in the list? Bronchiolitis, right? So certain conditions, so present at more common in a particular age group, right? So that's one reason why you want to know the age. Or the other reason, again for prescription writing, we need the age, and some drugs, like some drug dosages are depending on the age. Say in acute severe asthma, if children is under 5 years of age, we nebulize it. How much? 2.5 milligram of salbutamol, and we prevent 125. Above 5 years, we go for 5 milligram of salbutamol and 250 milligrams of micrograms of ipraven, tropium bromide, right? So some condition we use the age as a guidance for the. Commonly we use the weight to decide the dosage, but in some drugs we use the age for the drug dosage, right? So that's why you want to know the age. So if somebody asks why you want to ask age, that's the reason. Gender, why do you want to know gender of the patient? Yeah, now if we say a child coming with a painful swelling of a knee joint, if that is a girl, you won't diagnose hemophilia, right? Whereas in a boy coming with acute onset hemarthrosis of the knee joint, hemophilia come up in the list. Similarly, a child coming with hematuria or not hematuria, a red color urine, right? Passage of red color urine. If it is a girl, we don't diagnose, we don't take the DD into, we take DD as GCPD deficiency, right? GCPD deficiency is excluded in the differential diagnosis because it's a girl, right? So because some condition like extreme recessive conditions, we don't encounter generally in females, right? So that again, that's why reason we want to know the gender, right? So that's the reason. Location means where they come from, right? Why do you want to know where they come from? What the purpose of knowing life factors or what? Can you explain it more? Can you elaborate on it? Right, good. Yeah, so especially some diseases are common in certain area, right? So, like thalassemia common in northwestern and north central provinces, right? When there was malaria in this country, there are areas which are common in malaria. And then we know there are certain pockets of sickle cell disease in this country, right? So if the patient is coming from that particular area, then we think of that conditions are thought. Location means not the exact address, the area the child comes from, right? So you should know actually which part of the country this area located, right? So sometimes they might come out with the name of a town or a village which you have never heard. What you should do then? ජීවිතේ පළවෙනි පාට අවුන නමක් කියනකොට නම කොහෙද ගම කියලාම ජීවිතේ අහපුණද නමක් කියන්න පුළුවන්. ඒක මොකද කරන්නේ? Yeah, ask the nearest village town. ඒක අහන්න district මොකද කියලා අඩු ගන්න. Right? So that you know exactly. So if the examiner asks where are these villages, if you look up and down, then you look a fool. Right? So you should have a rough idea which part of the country this child is coming from. Right? That's why you want to know the location. Not just because somebody has asked you to do this. Right? So one reason is that's the diagnosis. Any other reason why you want to know the location of the patient?
Sometimes the distance from the home to the hospital will be important in the management of the patient and in the
Can you give an
emergency.
example? An example?
In a child with seizures, quickly patient will come to the hospital within few minutes like that.
Yeah, so that means sometimes the seizure disorder, right? So say a child coming with afebrile convulsion, right? First episode of afebrile convulsion. Then that may be the only convulsion child is going to have. So if you start anticonvulsant, then you'll be treating unnecessarily with potentially toxic treatment, right? So the child is living next to Ragama, and then his seizure is more of typical type, and you think it might not recur again. The history, the development, birth, everything is normal, no family history of seizures. Then you might not start anticonvulsants on the first episode, right? You might wait for second or third episode to start it. Whereas child coming from far away, say in an island in Kalpiti, then another 1 hour to come to the hospital. If child develop a fit, he might have traveled 3 hours before get to a medical facility. So a child might die of it because of the delay. So in that situation, you might decide to start anticonvulsant even with the first episode, right? So management decision, same like in asthmatic, right? Acute asthmatic, you won't start prophylaxis or not. Child living far away in a distant place, delay in medical assistance, then you might start inhalers early, right? So that again, you need to look at. Anything else? Any other example why location important? Say you get a child, you diagnose child rheumatic carditis at Ragam Hospital, right? And the child is from Putlam district. From Putlam. What will you diagnose rheumatic carditis in a patient who is residing in Putlam? So what is the importance of location in that particular history? Any idea?
So for the long-term follow-up and
Yeah. So what particular management part of the management? So what this child needs? Long-term management. If she is rheumatic carditis, you need benzodiazepine penicillin every 3 weeks, right? The child who had been diagnosed with rheumatic carditis need to be given benzodiazepine penicillin every 3 weeks, right? So he'll have to come to Ragam Hospital from all the way from Putlam to get the benzodiazepine penicillin if you are going to manage him at Ragam. But he'll be crossing several hospitals, base hospitals. Base hospital Putlam, this hospital Maravilla, this hospital Killau, this hospital District General Hospital Negambo, and then come to Ragu. So he passes several hospitals which have the facility to give the penicillin, right? So you can easily transfer that patient for the further management to one of these hospitals, right? Rather than get the patient in the patient in the Ragam hospital, right? So that's again why we want to know the location of the patient, right? To utilize the maximum facilities available in a local locality, right? Fair enough, right? So now you got why we take history, right? So history ගන්න එතකොට මේ ගන්න හින්දා නෙමෙයි. ගන්නවට ගන්නව නෙමෙයි. ගන්න යම් අවබෝධයක් හේතුවක් ඇතුව, right? So that's on relevance of each information you are taking. So you might have just take the history before, but now you take it again. Remember this, right? Each, even a small component of history, there should be some relevance to the management or diagnosis. Any questions about that? Are you clear? Anything you want to clarify?
Yes, sir.
You can say Master Pasindu, a 5-year-old boy from Nagama, right? That's the first description, right? Not like that. Master Pasindu, 5-year-old boy from Nagama. That's all. And then informant. Because one of the important part of the history presentation is the informant. Informant means from whom you got the history, right? Under what capacity? Commonly it will be mother, right? But then sometimes it can be a sister or a grandmother or an aunt, right? So you have to say who the informant was and or his understanding about the condition, right? Whether he is a housewife, she's a housewife, she's a teacher, he may be a doctor, he may be a medical student, right? And sometimes it may not be the mother. So why is important table about the informant? What is the relevance of that? What is the advantage of dealing with the informant is?
To determine the reliability of the history.
Good. One thing is anything else? Only reliability, what else?
If we are going to advise on something related to the management, whether he or she could understand the information that we are giving to follow up or in the
Okay.
relevant to the child, sir.
Okay. Good. Yeah. Good. Anything else? Say it's a grandmother or an aunt. Not the mother is there. Then what is the relevance?
It depends whether they are with the child at all times. For example, if you are prescribing a drug like an asthma inhaler, if they are there to supervise that, or whether someone else is giving it.
Okay. History පැත්තෙන් අතොත් දැන් as management history.
The reliability of the history may be changed because if it is aunt or something, when the onset in the onset maybe they.
So say aunt might not know about the birth history. Aunt might not know about the developmental history, right? Grandmother might not know about the immunization history, right? So when you come out with that information at the beginning, they can difficulties in getting the history. They will not bother you too much. More that you would have had difficulties in taking the history, right? Then again, we know that you would have had difficulties in getting some information. Maybe some might not know detail about management. Mother might not know the drugs child is on. Mother might not know the name of the university child has had, right? Then that give protection against for you. Similarly, if you say mother is a medical registrar, then we know your mother would have told you everything, right? Then you can use the names of the drugs, investigation results, right? Plans of management, everything mother will tell you. Then again, that will protect you other than X and Y loss, how do you know those information? Right? So it's very important to tell who the informant was. So you can say 5-year-old master passing to 5-year-old boy from Ragama. His history was obtained from the mother who has studied up to GC ordinary level. So that, right? And again, don't come and say my patient is. It's not your patient, right? So one good way of opening statement is, this is the clinical master passing to the 5-year-old boy from Ragama. The history of information was obtained from the mother who studied up to GC ordinary level. That will be very good opening for you to have the rest of the discussion, right? Right. And then you have to go for the presenting complaint. What is the presenting complaint? What do you mean by presenting complaint? What do you mean by presenting complaint?
The immediate
Open the presenting again.
to the hospital.
Yeah. What brought the child to the hospital, right? So if you ask a mother, they'll have 100 problems. They'll have 100 complaints about the child. Schools pass කරන්නේ කියයි, චූකර දනනවා කියලා කියයි, අහද්දල් කියනවා. But you have to figure out what are the major issues in this history which made the child to come to the hospital, right? So identify them. Don't have big list of presenting complaints, right? So say child presenting pneumonia, having fever, cough, and shortness of breath. He may be having constipation as well. Or don't put the constipation there in the presenting complaint. It make everything a big tumble. So you can now use that information of constipation in past medical history or somewhere during history of presenting complaint, right? So don't put that unnecessary information into history of presenting complaint. And you have to make sure that you give them in order of chronological order. The same order they have appeared. So like a child has respiratory tract infection, then you have to say child had fever of 5 days, cough of 3 days, and shortness of breath of 1 day duration, like that, right? So in a methodical order. So if you want to use the number of calendar dates, then you can say child is having fever since 20th of October, and cough since 25th of October, and shortness of breath since 28th of October, right? So either use the calendar dates or number of days. Don't tell like this. Child was having fever since 25th of October, cough for 5 days, and having difficulty in breathing for 1 day. So there you are mixing up the number of days and the calendar dates. So for somebody who's listening to you, make it very difficult to understand you, right? So if you are giving a detailed history of long-term history, like for example, you might go for a calendar days. But if you short history, number of days will be better, right? So depending on the present condition you are going to deal with, right? So anyhow, importing or presenting complaint is that you have to don't have a big list of presenting complaints. Arrange them in chronological order. Use either calendar dates or number of dates to present it, right? And if anything is unclear for you, can stop and ask, right? And then comes the history of presenting complaint. Now this is the bulk of the history, right? In a normal presentation, this is the bulk of the history. So this includes everything about the details about all these child's problem, right? or raise hands? Okay.
No, sir, it was a mistake.
Okay. Okay. Right. So, if you can locate the child, if the child has been a normal child up to this problem, then you can always say child was apparently well up to a particular age, and then from that day onwards, you can describe what happens. But commonly in pediatric practice, patients are chronically ill. Some babies are having problems since birth. Some patients are having problems for about a couple of years. Then you can't find a date even when he was apparently well. Right? They're not going to do that situation. And that's a very common problem in pediatrics. And sometimes there's no presenting problem as well. The Maypara again, repeat exam, a lot of patients who came who are in chronic problems. Some are actually admitted for the exam purposes. Right? Some will be admitted for the clinic. Some will be coming to change the management, change the drug regime. Some may be admitted for some investigations. So when they come for the investigation, we get them and get for the exam. And some have come for blood transfusion. Some have come for factor VIII prophylaxis. Then no presenting complaint. So sometimes, so you come and tell presenting complaint, patient was admitted to the exam. Right? So then it looks like it too funny, right? So ඒකේ මොකද කරන්න? ඒ වගේ වෙලාවට.
If it's a diagnosed
It is easy. Yeah. In the end, you have to start saying that this is a diagnosed patient with thalassemia admitted for routine blood transfusion and go from there onwards. Or you can say this is a diagnosed patient with hemophilia presented with swelling of right elbow joint. Right? Then you know child can't tell where he was better earlier. Or you can say child who is having seizure disorder admitted for his revival of his epileptic management. Or child with chronic asthma who was admitted to assess his inhaler therapy. Like that. Right? So presenting complaint, so don't expect a presenting complaint in each and every child. The child comes with urinary tract infection, child comes with acute gastroenteritis, child comes with pneumonia, viral fever, dengue fever, right? They will have an acute problem. They'll say, okay, 5-day duration, 6-day duration, 7-day duration. Right? But others might not have a presenting complaint, right? So be ready, right? Don't mess it up, right? Is it clear? How is it? So if you have a clear-cut history, like say a new child with respiratory tract infection, a child who had fever, cough and shortness of breath, we take a typical issue like that. Then how you proceed with the history of presenting complaint? Say child was apparently well up to 5 days ago. Then he developed fever, right? Then more can it. What do you say of that? So we are taking example of a child with respiratory tract infection, right? Who had fever for 5 days, cough for 3 days, and SOB for 1 day. So how are we going to proceed with the history of presenting complaint? So you say child was apparently well up to 5 days ago, and then he developed fever. It is more again. What are you going to tell after that? You go on describing everything about the fever after that, right? All the features of fever before you move on to the existing symptom. Whether the fever was how high fever, it is high fever, whether you are associated like chills and rigors, whether the fever came down without any treatment or you needed antibiotics to bring down the fever, they are settling of fever, whether the fever came down to the baseline before coming up again, right? And whether there was a fever-free period in between two fever spikes, and then whether there was rashes or any other associated symptoms with fever, right? So you go on describing each and every aspect of fever before you move on to the next symptom. So once you finish everything about fever, move on to the cough. What type of cough is it? Wet cough, dry cough, productive, and then what time it was worsened, morning, night, or daytime, and then did it come out with bouts of cough or just occasional coughs? Was there any association like whoop-like thing in that? The child had vomiting after coughing, right? So everything about cough after that. And then you go on to the short subject part of it. Tell about how child was having difficulty in breathing, how breathing difficulty, everything about short subject afterwards. Right? So that's how you describe the symptoms in the history of presenting complaint in straightforward case. Right? Any questions about that? Any questions about that? So in case like that, it's easy. But in case like, I say, a child, now we part example, child, nephrotic child coming with fifth relapse, right? So this child came, had 4 previous episodes of nephrotic syndrome, came with this time with generalized edema. And one candidate came to us and then he was trying to give a differential diagnosis for edema, right? And he was trying to prove this is nephrotic syndrome, right? I was talking about protein losing enteropathy, then malnutrition, right? Heart failure. So he was spending a lot of time trying to prove that this edema is due to nephrotic syndrome. And I intervened because he was losing valuable time. So I said, was this a diagnosed patient? They said, yes, nephrotic syndrome patient. So then we asked them to go on to the nephrotic history. So you are just wasting your time if you just try to prove that it is nephrotic syndrome when it is crystal clear. Mother will tell you it's nephrotic syndrome, and when all the history is available is nephrotic syndrome, no point you trying to prove this edema is due to nephrotic syndrome, right? So in that case like that, you can straight away start like saying that a 5-year-old boy, the same history, 5-year-old Pasindu, this is the clinical history of Master Pasindu, 5-year-old boy from Ragama. History was taken from the mother. It's a diagnosed patient with nephrotic syndrome, presented with generalized edema for past 5 days. Right? Then you can start, you have opening to discuss for nephrotic syndrome straight away. Right? You don't have to go differential diagnosis for nephrotic for a edema. So what you want more is go into detail about the management and past history and find out what type of nephrotic syndrome it is. Right? What we want you to figure out is what is the type of nephrotic syndrome child is having. Not whether it's a nephrotic syndrome or heart failure. Right? So remember that. Don't waste time trying to diagnose an already diagnosed condition, which is mother is knowing, and the history is clear cut that it's a diagnosed patient. Right? So if in nephrotic syndrome, you start by saying that child is apparent well up to 2 years of age when he developed generalized edema, and then he was admitted and you describe what happened during that episode. How it was treated, how long it was treated, or any complication during that episode, and then you go on telling what happened afterwards. So each episode was same as earlier. Then you say all the episodes are similar, but the management was different. And then you can say what was the current management just before this episode, right? And then go on what happened during this time, right? Understood? So depending on the case you have, right? And you can get child cerebral palsy, right? A child cerebral palsy or child seizure disorder who has come with, you might come with acute gastroenteritis. Say 5-year-old boy with cerebral palsy admitted with gastroenteritis. Now, how are you going to present that history? Can somebody tell? How will you set about the history of presenting complaint? Am I going too fast? Hello? Can you follow my speed?
Yes, sir.
Yeah. Too fast, Nani?
No, sir.
Right. So, say a child with cerebral palsy is admitted with acute gastroenteritis. how are you going to set about in history of presenting complaint? Can you try it? Have a go at it. So you can start by saying presenting complaint diagnosed patient with cerebral palsy, admitted with watery stools of 3 days duration and vomiting for 2 days duration and fever of 3 days duration, like that. 1 day duration, right? So like that. So you can start telling that it is a diagnosed patient with cerebral palsy. So you have opening to discuss cerebral palsy in the history of presenting complaint straight away, right? So when you come to history of presenting complaint, depending on how significant is the presenting complaint, you can either decide to describe the present problem or straight away go to the cerebral palsy history, right? So if the diarrhea is a significant issue, you can say, you can go on describing about the diarrhea in the presenting complaint, right? But the diarrhea was not significant. You can say that because the child's problem started since I birth, so I'll describe the history from the birth, and you can go on starting from the birth history, right? But if you go like that, don't forget to discuss about the current problem. Why child came to the hospital. Pneumonia patient in cerebral palsy you go on describing cerebral palsy history, you forget totally about the current problem. That can be lead to failure, right? So remember, you can start from birth history in case like cerebral palsy, right? But if it's acute problem, you better go for the acute problem, right? And then say child is a seizure disorder. Child having seizures since 3 months of age and still on medication, recurrent seizures are there. While on medication, then what do you do? You can start saying that child with a seizure disorder since age of 3 months. I would start with the birth history because it's relevant to the birth history, right? So the birth history can be incorporated into the presenting complaint. Sorry, history of presenting complaint, depending on the condition, right? So as I told you, each part does not need to be in the same order, right? If you think the birth history is relevant to the history of presenting complaint, you can incorporate the birth history into the history of presenting complaint. Then again, you would have to tell it again at the end of the history of presenting complaint as different part of the birth history, right? Are you clear?
Yes.
So you go on describing past history, what happened, because now see an nephrotic child coming with fifth relapse, right? All 5 episodes before that first episode have 4 relapses. Are they past medical history or it's a presenting complaint? Nephrotic relapse එකේ කාපුවාම එයාගේ පරණ episodes past medical history the history of presenting complaint. That is history of presenting complaint. It's part of the present problem, right? It's a different problem, right? So you have to describe about past episodes in the history of presenting complaint, right? Whereas if child has had a febrile convulsion in addition to nephrotic syndrome, then that febrile convulsion is a additional thing. It goes into the past medical history. Right? So if child with a seizure disorder, epileptic, admitted with the acute episode of seizures, breakthrough seizures, right? Then presenting complaint is the acute onset seizure. But all the past seizures are related to the present problem. Right? So you have to describe all those episodes in history of presenting complaint, not as a past medical history. right? So the past medical history includes everything, all the other illnesses, apart from the problem that child has presented with, right? And in surgical histories, allergic histories, all are incorporated into the past medical history, right? So in the history of presenting complaint, in addition, you have to tell about all the, if you diagnose patient, say a nephrotic patient, you have to tell about the etiology, what are the possible etiologies, and then what are the treatment child has had, and then what are the complication child has had, complication due to disease, complication due to the treatment, right? So everything should be told in the history of presenting complaint. If you have a diagnosis, right? If he is a thalassemic, everything about blood transfusions, what happened, type of blood is given, blood group, reactions to blood transfusions, all should be given in the history of presenting complaint, right? And the කියද්දි පරිස්සමෙන් දැන් nephrotic syndrome කරලා ගොඩක් තමයි කියනවා no history of malaria කියලා. Nephrotic history එක කමුණාව etiology එකට malaria හැදලා නැහැ කියනවා. What is the history information? They say no history of malaria. Is it a valuable statement or not? Can malaria cause nephrotic syndrome? Yes or no?
Acute complication of as a complication in plasmodium malaria, it can cause nephrotic syndrome.
Yeah. As a complication of plasmodium malaria, you can get nephrotic syndrome. And do you have plasmodium malaria in this country?
No.
No. Right? So we had now our malaria eliminate. But when we had malaria in this country, what we had was Vivax and falciparum. We didn't have plasmodium malaria infection in this country. So true that plasmodium malaria infections cause nephrotic syndrome, but not relevant to our country, right? So just by telling that, you follow unnecessary trouble. Examiner might ask you, why do you ask that? Then you have to say malaria causes nephrotic syndrome, and then what malaria that causes nephrotic syndrome must be malaria. Is it occurring in Sri Lanka? It's not in Sri Lanka. So why you ask it? There's no reason. Right? So you try to show off your knowledge, but then you show that you don't know actually what it means. So be careful, right? When you're telling, it should be relevant to the particular problem. And falciparum malaria can cause acute glomerulonephritis feature, right? Not a nephrotic feature, right? So malaria is not relevant to nephrotic syndrome history in Sri Lanka, right? So that is what about history of presenting complaint, right? So anything you want to clarify? If you have any problems during your history taking, or you want to clarify anything about that? Anyone? You want to clarify anything?
Sir, if the patient was coming from being admitted to some other place and previously treated in between the episode before presenting at this hospital, should we elaborate in detail of that episode and how he was treated in the history of presenting complaint?
Same illness, yes. They transferred, patient transferred to some hospital.
If he was
patient
treated
transferred from some hospital, or they come.
No, sir. If the patient went to a clinic or OPD and was treated previously, should we?
It's a chronic patient or acute patient?
Acute patient, but he had been to some other place before presenting here.
Yeah, then you have to tell about what happened from there.
Okay.
From the beginning. From the beginning of the history of presenting complaint, you have to describe about the present illness from when he was ill. So you can say child was admitted with history of fever for 3 days, right? Kela, then you have to say, apparently, if a person complained, child was having, has had fever about 1 month ago, and then was treated with these things, and then child was having one and fever again. Manage how to manage.
Okay.
So you have to, if it is current problem, if it is related to the present problem, you have to describe the present problem as well. Start from the present problem.
Okay.
So it's different from each patient, right? So you can't have a set format. So you can't have a set format and use that format to every child. Each is different. So you have to make sure that you can adapt into each situation rather than taking the same history for every patient. Right? So then we move on to the other thing. So past medical history is about all the illnesses a child has had apart from the present problem. Right? So for a nephrotic child, everything about nephrotic syndrome is history of presenting complaint. Child with thalassemia, everything about thalassemia is in the history of presenting complaint. Right? So a child with hemophilia, everything happened about hemophilia in the past is history of presenting complaint, not past medical history. Right? Past medical history is other medical conditions or surgical conditions not directly related to the present problem. Right? And then you move on to the birth history. The birth history starts from where? Birth history starts from where the parents got married. Right? So it is consanguineous parents or non-consanguineous parents. Then whether it's a planned pregnancy, unplanned pregnancy. Then when was the diagnosis, when was the pregnancy diagnosed, at what stage, what gestational age, when was the first booking visit, and whether mother attended clinics regularly, whether there's any antenatal complications, whether mother received tetanus toxoid and other vitamin supplements, whether mother has had rubella vaccine, and then what type of delivery was it? Normal delivery, cesarean section, vacuum extraction, forceps delivery, where the delivery took place, a teaching hospital, base hospital, and when the baby cried at birth, when the baby has to be resuscitated, when the baby taken to special care baby unit, when was the baby was special care baby, what happened in special care baby unit, antibiotics given, phototherapy given. So everything about birth should be in the birth history, right? That is a detailed birth history. Now, are you going to take this detailed birth history in each and every child come to you? Only some children. හැම බබාගෙම ඔක්කොම අහනවා දිගටම ඉස්සර. එහෙම අහන්න ඕනේ නැහැ. So say a child who is having cerebral palsy, a child who has a developmental delay, a child who has a seizure disorder, right? Something to do with central nervous system problem. Then you have to go into detail about birth history, right? But a child, a 10-year-old boy, previously healthy child, coming with acute gastroenteritis, are you going to ask all this detail in the birth history? No. And you don't want to tell about them in the presentation as well. Then you're wasting time, right? So because it's not related to the present problem. So you can just say the child was born by normal vaginal delivery or cesarean section, but there were no birth-related complications. That's all. Full stop. Right? We will not go to detail about other things. But if child has had a problem, even it's not related to the present problem, you have to go into detail. Say a 10-year-old boy coming with acute gastroenteritis, but child has had problems at birth. Being shy, was taken to special care baby, given antibiotics for 21 days, right? So a lot of complications have taken place. In that case, you have to tell it. Right? If it is positive. If it is negative, you have to go on telling all these things. So it depends on the case, whether that particular information is relevant to the particular history, right? So depending on the significance, you go on to detail history about that particular history, right? So otherwise it's not relevant. You can just say his child was born by normal vaginal delivery, no birth-related complication, right? And then if you have a significant birth history which is related to the present problem, we can start it with the birth history in the history of presenting complaint as well, right? And then there's immunization history. Now, what is immunization history? It's about all the vaccines child has received. The child received them in the government sector, private sector. All the vaccines were given at correct time, age-appropriate immunization. Then with the child are developing reaction to immunizations, the child has had any additional vaccines from private sector, right? So everything about vaccination you have to ask in the immunization history. Again, I am going to tell all these things each and every child. No, right? So supposing you have a child who is coming with acute flaccid paralysis, the weakness in the limb, like Guillain-Barré syndrome, then you have to go into detail about the polio vaccination. A child coming with a chronic cough, you have to go about specifically ask about the BCG and the whooping cough vaccination, right? But for a child coming with acute gastroenteritis, again, acute gastroenteritis at 10 years of age, then the immunization history is not that relevant. So in that case, you can only say the child has received age-appropriate immunization and child has not received any additional vaccines. That's all, right? But if child is coming with a chronic cough, 5-year-old boy coming with chronic cough, then you have to tell the child has received BCG at birth, and child had a reaction of BCG, and child has a BCG scar, and child has received 3 doses of pentavalent vaccine, and then at 18 months old, child had a triple vaccine, right? So if that particular, for that particular case, if the vaccination is relevant, then you have to go on elaborating on that particular vaccination, right? So sometimes mother might come and say, child has received all the vaccines. But if you go to history and see, child developed a reaction 2 months vaccination, high fever 2 months vaccination, and then child will not be given pentavalent at 4 months and 6 months. Instead, they will be giving DT vaccine, which contain diphtheria and tetanus only. So child will not receive pertussis vaccine, right? So you think, okay, age-appropriate vaccine have given, but then to look at it, child has not received pertussis vaccine. In that case, the pertussis comes as an important differential, right? So depending on the case, you have to decide how relevant is the particular immunization history. Then you have to go in detail about the immunization history in that case. So again, what I'm highlighting here is each part of the history depends on the importance of each part depends on the history itself, right? Is it clear? Clear, Nader?
Yes, sir.
Right. Any questions about that? Then nephrotic puppy cow, the nephrotic child. Then you have to tell about the child has received varicella vaccine and pneumococcal vaccine additional. Amatarva. Normal Ganada Amatarva, because they are more prone to develop pneumococcal vaccine infections, and if they develop chickenpox, they can have severe reaction, right? So because of that, we want to ask about child had those vaccinations. Say a child with thalassemia having a large spleen, then you want to know child has received pneumococcal vaccine and hip vaccine and meningococcal vaccine, because child might need the splenectomy, and if splenectomy is done, then we need to know whether child has had these vaccinations. Again, child with chronic ITP, then we might end up with a splenectomy. In that case, we want to know child has received pneumococcal vaccine, hip vaccine, and the meningococcal vaccine, right? So in that particular case, you have to ask separately about the other vaccines, right? So it all depends on the condition you are dealing with, right? Then comes the developmental history. Developmental history is about the child's achieving the milestones, right? The way child develops the living skills. So we describe it as 4 headings: gross motor, fine motor and vision, hearing and speech, and social, right? So in each domain, you have to ask few questions and see whether a child has developed the milestones at correct age, right? And whether there have been delay in milestones, or there have been any loss of milestones, right? So you can ask about each domain and ask some questions to know whether the child development is age appropriate or not, right? So again, it depends on the case, right? A child who has epilepsy, cerebral palsy, seizure disorders, developmental delay, then the developmental history becomes the most important part of the history, right? So you might have to incorporate the development history into the history of presenting complaint, not a separate one, right? So you have to go to detail about development, each and finer details about development in that case, right? But if a child has coming with a pneumonia, a 8-year-old boy coming with pneumonia, if his development has been normal, then you do not ask about detail about development. You can just say there are no developmental concerns, right? There have been no concerns about the development, right? So depending on the case, you have to dig into the history, right? Is it clear? Hello.
Yes.
That is development is so it depends on the case, right? So don't waste time on developmental history if it is not relevant to the present problem, right? And child has normal development, don't go on begin to it. So you're supposing mother say I can't remember development milestones. What are you going to tell? What are you going to ask? Mother has 5 children and mother can't exactly remember each and every child's development milestones. What are you going to ask?
Comparing the other children's milestone.
Yeah. So you can ask considering other children, did you have any worries about this particular child, right? So if this child had problems, he should remember this child was different from other children. So in a present, you can say mother cannot remember exact age of achieving milestones, but there have been no concerns about this child's development compared to other children. So you can say that. So you can save your life in a way, right? So that's how you handle the developmental history, right? Then the dietary history. Dietary history is about the diet child has had and now what he is having now. So dietary starts with the time of birth from breastfeeding, right? When the baby was fed within half an hour of birth, whether he was exclusively breastfed, whether he was going to formula feed, there are feeding difficulties, right? When the complementary feed started, whether there's problem with complementary feeding, the formula feeds were given, right? And so on. So everything about dietary history, and then you have to ask about recall and now morning to evening. Does he have milk in the morning? In between snacks, what he has, and you have to have a rough idea about what the child has had during a routine day. And you have to roughly calculate the calories and proteins in the diet. And you have to come out with the conclusion whether the diet is adequate according to the calories and proteins, right? That you have to do, right? It may not be accurate, but you have to have some rough idea, right? So at the end of the day, what we want to know is whether you have taken a dietary history to find out if this child has any problem with the diet. So say a child who is on dark green zone, mean plus 2 SD or mean plus 1 SD. You have to go into detail about dietary history. දිගටම 3HDR එකේ බබා ඉන්නේ අර mean plus 1 SD එකේ, right? Towards on the birth. Do you have to go into detail about dietary history? What do you think? No, right? Because diet එකේ ප්‍රශ්නයක් තියෙන බබාම go වෙන්නේ නැහැ, right? So it's important. So make sure that you are familiar with CHDR, right? CHDR is given to you in the exam. Diagnosis cards, investigation reports, nothing will be left with the patient, but the CHDR will be left with the patient. So any information available in CHDR is accessible to you. So make sure you know what is available in CHDR. What are the information you have in CHDR and where to find it, right? Details about birth, details about the immunization, development, growth are available in CHDR. And the reliable information you can utilize in the history, right? So make sure you look at the growth chart and see the pattern of growth in the child. Don't miss that. That is very important information. And be familiar, because you can just glance at it and get the information without wasting time, right? So, but if a child is on, say, child was on green zone, dark green zone, up to about 7 months, then he has started falling off his centiles. Now he is on orange zone, then